Welcome everybody to Scanbalt Digital Forum 2020 first session. Our session is titled Digital Solutions for European Cross-Border Collaboration in Healthcare. My name is Peeter. I'm a professor of e-health in Tallinn University of Technology, and I'm also a radiologist. So I daily use quite a lot digital tools. We heard excellent speeches about the usage and importance of digital health and medical data during these keynotes. And our session now is about cross-border collaboration. We will have 6 very interesting presentations. They last 6 to 7 minutes each. We won't have questions after each presentation, but we will then collect questions for the panel, which will take place at the end of this session after all presentations. These presentations actually will look at the cross-border digital solutions from different perspectives. So I think this will be a fascinating session. It will last 75 minutes. We will try to have around 25 minutes for the questions and panel discussion. Now I'm happy to introduce first presenter, Dr. Corinna Glasner. She comes from University of Groningen, University Medical Center, Netherlands. And her talk will be about antimicrobial resistance and how the Dutch-German cross-border region has been at the forefront in cooperating in this domain and in infection prevention since 2005. The title of the presentation is Innovations for Safer Healthcare in the Dutch-German Cross-Border Region. Corinna, the floor is yours, please.
Hello everyone, I'm Corinna Glasner, and today I'm going to talk to you about the innovations for safer healthcare in the Dutch-German cross-border region. And first of all, I would like to thank the organizers to give me the chance to present our work here to you today in this digital time. Let me take you to the Dutch-German cross-border region, which is displayed here in a couple of nice pictures. And as you can immediately see, it is not really a border anymore. Actually, I've been driving over it over the past 4 years, almost weekly, and you don't even see or feel the border anymore. And interestingly, the Dutch-German cross-border region is one of the regions which is being crossed the most in all of Europe, which was the result of a survey done amongst European border citizens. And why do people cross the border? This is usually because of leisure and tourism, buying goods and services, or visiting friends and family. But if you think about the two countries in its whole, what people usually think about when they hear Germany are, when they hear the Netherlands are those kind of pictures, and when they hear Germany, those kind of pictures. And that is actually always what I like to show as well in my presentations, because culture plays, of course, a very big role in our daily work that we do. And those are the pictures that usually have been thought of our countries. But now coming to our field, and my field is the field of antibiotic resistances, pathogen, infection control, infection prevention. And we work in the north of the Netherlands and in the northwest of Germany, which is displayed here. And here's just one example of data, which is antibiotic use. And interestingly, the closer you get to the border, which is depicted in the middle with a pink line, the higher the antibiotic use seems to be. You can also see Groningen, that's the location I am at the moment actually. And what is also seen in those pictures is that if you think regionally, which is even much more important than thinking nationally, especially in our field, because you see very, very big differences between the different regions. So this is the world in which we live, in which we work, and in which we try to improve things in healthcare for our patients. what we also did is actually we compared our healthcare systems, and one would think now, wherever you are in this world, oh yeah, but the Dutch and the German healthcare system, they're very similar because they're next to each other. But that's actually not the case. Actually, our two healthcare systems are very, very different. And how we call this is like so close and still so different. It's a chance to learn from each other and a chance to work together. Because what we actually try is that we pick out the things which are the best in each of the two, and then try to combine them and help each other and work together where it improves the situation for our patients. And now I'm going to talk to you about our cross-border AMR projects, which are Your Health, One Health and Health Care, two very large projects financed by Interreg over the past 4 years with around 50 partners from science, business, and health who work together in many, many different work packages, innovations, milestones, with goals of education, interventions, competence, research, many, many more. I can't talk about everything because then we would be sitting here for many, many hours. And I actually cannot even talk about Your Health, One Health. Today, I just want to talk about healthcare care. And healthcare care is our project, our innovation project, which is based on 30 small and medium-sized businesses who work together in consortia. And each of the consortia had to consist out of partners from both sides of the border and partners from science and health institutes. And together they worked on innovations to improve healthcare, of course, with a focus on antibiotic resistances, pathogens, and infection control. And these kind of innovations are, for example, software, point of care tests, or for example, new antibiotics, a lot of different ones. And again, here, I cannot talk about all of them, so I picked 6 out to present to you today. The first one is a specially developed soap or sterilium dispenser for children to improve awareness and improve prophylaxis with and for children. It was tested in elementary schools, but is of course applicable to all locations where children need to wash their hands or need to learn to wash their hands. And here's a very nice picture, and we did a lot of different interventions with the children to improve their hand hygiene. The next innovation is called Motivare, which is a software tool. And it's an online software tool free of charge. If you want to access, you can contact me, where you can put in patient movement data. And with this patient movement data from your hospital or your healthcare region, you can identify the hubs in your hospital or region. And those hubs are the points that are being passed by patients the most. Thus, we think that if you focus your infection prevention and control measures on those points, you already can change a lot and improve a lot for your patients. And on the other hand, if you have an outbreak, by that you can identify departments which are closest to your hub, which has the outbreak. And as the last one, I just want to give you a brief overview about 4 more innovations, which is Checkbuster. It's an audit software tool, for example, to do audits for infection prevention. And it's actually trying different lists, and it's very custom made. We have the software called Anne for Care, developed by Virtas. It's an avatar for elderly to support them in their daily life. We have the software Ellen, and actually Ellen Evaluates, and Ellen Evaluates, which is developed by eLabs in our region, actually helps staff in an operating theater to give feedback to each other and to improve also here the infection prevention measures after a surgery. And last but not least, we have the software Bacter, which is a hygiene training developed by our company Cool Minds. And with that, I'm actually already at the end of my presentation. Here's a brief overview again. And actually, since our innovations that we developed and are still working on are not very specific and in general are to improve patient care, improve infection prevention, it is also, of course, applicable for COVID-19, which is currently holding us hostage, basically. And with that, I want to thank you all very much for your attention. And I'm very happy to hear your questions. Thank you very much.
Thank you, Corinna, for those very interesting cases and apps that you have developed. Our next speaker is Sarah Lidé. She comes from Denmark and actually from the Greater Copenhagen region, from Medical Valley Alliance. She's going to present Medical Valley, which is a vibrant transporter Danish-Swedish life science cluster that is part of the functional region of Greater Copenhagen, and she will share on why a common health data space would support the specific needs of the Greater Copenhagen region in COVID times. And the title is The Case for Data Across Borders. Please, next presentation, Sarah.
Hi, my name is Sarah Lidé, and I am a Senior Strategy and Project Manager with Medicon Valley Alliance. So we are a cluster organization that's serving the life science sector in the Greater Copenhagen region, which is a trans-border Danish-Swedish region spanning eastern Denmark and southern Sweden. As a cluster organization, we have more than 250 members from industry, academia, healthcare, and public organizations working with life science in the region. Now, the EU Common Health Dataspace is of clear interest to us, given the cross-border nature of our region and our own organization's desire to promote collaboration and partnerships across the Danish-Swedish border. Within Medicon Valley, which is the name for the regional life science cluster, we have more than 42,000 people working in the life science industry, and close to 15,000 researchers spread across the 9 universities in the region. And for Greater Copenhagen as a whole, it is a lively, functional region with 70,000 people crossing the bridge daily between Denmark and Sweden, of which 16,000 are commuters, and a vast majority of these commuters live in Sweden and work in Denmark. Now, this cross-border perspective has, of course, created an interesting situation in the time of COVID-19. While efforts across the globe tend to be national in nature, there are clear regional variations in the progression of COVID-19 that might also benefit from a regional approach. For example, this graph, compiled by News Øresund, shows that while on a national level, Sweden has a higher death toll than Denmark, the situation is quite different when we look at the regions which form Greater Copenhagen. And given the level of movement of people between the Danish and Swedish parts of the region that I described earlier, this builds the case for a common health-related data space that would support population health efforts and decision-making in a cross-border functional region such as ours. For example, the graphics shown on this slide are from an analysis that mobile operator Telia has supported the Nordic national governments with in tracking the movement of people through the use of mobile data. So these heat maps show whether the movement of people have increased or decreased in these regions. And the graphic in the center here shows start and end points to these trips as well. And such use of mobile data done at an aggregated and anonymized level provides a data-driven approach to support decision-making by policymakers and evaluate the effect of measures already taken, such as recommendations to keep distances and to avoid unnecessary travel. This next slide shows an ongoing research project led by Lund University in partnership with Uppsala University and Zoe Global, called the COVID Symptom Study. Now, this initiative involves an app that was first developed by researchers and doctors in London, where users report in their symptoms daily. The app clearly states that it's only to be used for research purposes and it's not meant to be a diagnostic tool, and it also doesn't collect personal identifiable information. And here you can see that it provides a real-time map of how the situation in Sweden is developing over time, both at the national and regional level, based on self-reported data. While these are 2 great examples on their own, bringing these multiple sources of data together could also generate helpful insights on, for example, how movement patterns could be impacting the spread of COVID-19. And this would be even more helpful if achieved across the borders of a functional region like ours, to inform decision-making and guidance in the specific evolving situation of our cross-border region. While this has much more of an immediate term impact, in the longer term, a common health data space will help in particular to accelerate research and innovation in life science. We already see that COVID-19 has sped up the impetus to share research data to get a better understanding of the virus. But even in a post-COVID-19 world, Nordics in particular have great conditions for sharing and harnessing health-related data, giving similarities in health systems and the use of personal identification numbers to connect various patient registries, which provides the opportunity to explore associations between lifestyle, environmental factors, and disease at a Nordic level. For Medicon Valley as a Danish-Swedish cluster, we see this as an important area of opportunity to increase the cluster's overall competitiveness, especially given the emphasis that both countries has placed on the life science sector. The Swedish National Life Science Office has explicitly mentioned the better utilization of health and clinical data as a key priority area. And we see value in exploring opportunities for aligning this ambition and Swedish health data assets with the Danish counterparts, such as the Data Saves Lives initiative, which also aims to ensure the better use of Danish health data. Such an alignment would serve to provide enhanced data volumes for conducting research. The Nordic Council of Ministers, in fact, published a report in 2014, which provides some great proposals here, including the establishment of a Nordic virtual center for register-based research. And this would take advantage of the Nordic elements of health data that I previously mentioned. At MVA, we are also taking steps in this direction, for example, through our Rep Union initiative. This is a public-private partnership in reproductive medicine, where academia, the healthcare sector, and the life science industry are collaborating to provide the best care with the most modern reproductive technologies to all patients in the Greater Copenhagen region. Since its establishment in 2015, Rep Union has, among other things, paved the way for a formalized patient mobility agreement between the capital region of Denmark and Region Skåne, which allows for the free mobility for some categories of patients with reproductive disorders within the region. From a data perspective, 3 out of the 5 challenges addressed in Rep Union are connected to the ambition to create a joint cohort and biobank, which would be a unique research infrastructure involving samples from 10,000 patients from both sides of the border. So to summarize, given that we are a trans-border life science cluster with residents living and working across the border, the case for sharing data is strong. In the immediate term, it would support population health efforts and decision-making during pandemics such as COVID-19, particularly when movement patterns span borders. In the longer term, a coherent and trustworthy common data space will help to accelerate research and innovation in life science by building on and connecting valuable existing sources of health-related data. With that, I end my presentation, and I thank you for your attention.
Thank you very much, Sarah. Excellent examples how cross-border research benefits society, and especially during situations like COVID. Or one housekeeping thing before we proceed with the next presentation. All of our sessions will have some polls, so please keep eyes open to participate in the polls. In this session we have one only, but later on there will be more. So we try to keep this now we proceed with the third presentation, which actually is run by 2 persons, Iris Meyenburg-Altvarg and Geir Arnhoff, from Germany and Norway. And this show is about using digital tools to cover the gap of the demand for nursing competencies in the COVID-19 pandemic. This presentation shares with us experience of supporting the onboarding and training of more than 1,000 new staff members in COVID-19 clinic. So please, I think Geir will start, and then followed by Iris, please.
Hi, I'm Geir Arnoff, the CEO and founder of Dossier. With the COVID-19 outbreak, we have seen governments and healthcare providers forced to shut down and regroup resources to ensure pandemic response capability. Responses have concentrated around two axes: meeting demands for physical supplies, such as PPE, ER, and ICU capacity. And secondly, ensuring medical staff with the right competencies. Europe experienced a shortfall of qualified nursing staff already before COVID-19. With the coronavirus, this situation has escalated. Imagine a 1,000-bed hospital. It serves a population of 250,000 citizens and has about 10,000 employees. Imagine yourself being responsible for the assurance of all staff to have the right skills and qualifications at the point of care. Today, tomorrow, and with all the changes going on, now with the pandemic. Dossier is a Norwegian software company. Over the last 10 years, we have been fortunate and honored to work closely with clinicians and providers, ensuring competencies at the point of care. More than 100 facilities and 500,000 healthcare professionals use Dossier today. On the initiative from Hannover Impulse, Dossier was invited to support the onboarding and training of more than 1,000 staff members to the auxiliary COVID-19 clinic in Hannover. In the matter of weeks during April this year, 2020, the Hannover project combined unique knowledge and experiences from all partners, enhancing an onboarding framework to train the staff for the Surge Hospital. Iris Meinburg-Altva. It has been an honor and a pleasure getting to know you and having the opportunity to contribute to this project. It has really reminded myself that nursing competencies is the skill to healthcare capability. Based on the experiences with retraining and reallocated nurses to meet increased demand, what do you think we'll bring with us into the future, both with and without the pandemic?
First of all, thank you very much for the introduction. I would like to put it in 4 points to understand it. First of all, it is the interprofessional and cross-training. What do I mean with this? If you have a pandemic or similar situations, everybody feels unsure what to do and how to do it. And so it needs an element of self-assurance to react adequate. This could be achieved by cross-training, for instance. The second thing, important thing, is the infrastructure. It has to be clear and easy to use. And to ensure that aim, the organization and the management need a clear structure for this necessary learning methods. And thirdly, it is the implementation of new and completely different learning methods. In time of pandemic, new and different learning methods are required that can be used quickly and successfully in compliance with the hygienic and up-to-date requirements. And that was one of our big challenges. And the fourth one, I would say, which is also very important, is actually the transfer task in time of social distancing. Because what we had in the hospital was we had our normal hospital and we had to transfer all the knowledge and the task to this auxiliary hospital with completely different people. And this transfer of necessary therapy tasks outside of our normal workplace in order to extend the needed capacities takes care to reduce the transfer of risks and also to avoid unnecessary contacts. That's my 4 points. I think it's very, very important. And of course, the people must trust it and believe in it. Thank you.
Thank you so much for sharing your experiences. And experiences from the auxiliary hospital are already embedded into other dossier projects to ensure competencies and increase patient safety. Thank you all for watching. For more information, please visit us at www.dossier.com. Thank you.
Thank you, Iris and Geir, for this very practical use case, which shows that borders are not only between countries, but also between organizations and sometimes even between departments. Our next presentation comes from Germany, and I'm happy to introduce Dr. Alexander Zink. From the University Hospital of the Technical University of Munich. He will talk about how to evaluate patterns of patients' journeys in a cross-national and multidisciplinary manner. He, as a practicing doctor, also gives a special focus on the role of digitalization in order to generate empirical evidence, which can be used then to improve people-centered care of chronically ill individuals. The title of the presentation is quite long, and it starts as follows: the European Patient Journey. Please, Alexander, the floor is yours.
Hello, everybody. I'm Alexander Zink. I'm a dermatologist, a trained dermatologist in Munich, Germany, at the Technical University of Munich. And I'm interested in public health and digital medicine, and especially during times of COVID-19, changing the European patient journey in terms of access to healthcare. So as a dermatologist and as a physician, I always believed that what's the typical way of somebody seeing a doctor, that if anybody has a medical problem, he just looks up a local doctor, goes there, has adequate treatment, and that's it. Probably many of you also think it's that way, but let's face it, that's not real life. In real life, the way is different, and after somebody has the first symptoms, the first thing is that there's a lot of time which is just lost. People look up different doctors, people talk to their friends, talk to their family, and of course, in the year 2020, they look up the internet. They look up search engines and especially social media. You don't talk to your friends in real life, you talk to your virtual friends and virtual doctors maybe. And during the COVID-19 pandemic, what we realized is that, of course, people couldn't go outside anymore, lockdown. So the internet became more and more important for everyday life, but of course also for healthcare. And in summary, after it takes sometimes years until adequate treatment. The way until somebody with symptoms sees a doctor is a very individual way. And we, until today, do not know what's really going on in this COVID-19 triggered digital importance of new ways of accessing healthcare. So that's what our project is about. The project is titled the European Patient Journey, and the aim is to understand cross-national and multidisciplinary patterns of digital patient journeys from the first symptoms until somebody sees a doctor and gets a treatment, but also to explore the role of digitalization, focusing on internet search engines, Google in Europe, and especially social media, as I said, the virtual friends, the virtual community in different European countries to, at the end of the day, generate evidence to improve people, not patient, but people-centered healthcare, as the WHO asks us for in terms of access to healthcare as adequate treatment for your symptoms. And what we did, the first step, what we did in Germany is we looked at the search volume of coronavirus in Germany during the COVID-19 pandemic, during the first 4 months of the pandemic. And as you can see, the first case reported in Germany was January 27, and immediately the search volume on Google for the topic coronavirus went up. That means that a lot of people were interested in coronaviruses and just looked up on Google, what is it? And as you can see, within the next 4 months, as the importance of coronavirus in Germany became clear, and as an increasing number of patients were reported and treated, also the Google search volume just dramatically went up. And what we found is that the search volume, the local search volume of Google was very well adapted to the real number of cases. So in summary, you can sort of understand it that depending on how many cases in your local area are, that has an impact on the local search engine volume, which is in Germany on Google, because 98% of Germans use Google. But what you can also do is you can exactly try to find out what are people looking for or searching for in terms of what is related to the disease. We're currently doing it for coronavirus and the pandemic, but we also did it a couple of years ago for the term itch. And as you can see, itch, people are not just interested in itch, but people are interested in what or different areas, because different body areas, because you have a problem maybe on your neck or your hands, and then you're looking up on the internet, what can I do, for example, against itch on my hand? And that can be analyzed. And as you can see here, the most search for body part in terms of itch problems is the anal area, which is quite interesting for a doctor, but also the legs compared to, for example, neck. The example I chose is not really a problem. And the next step is you can compare different regions. So we're planning to compare different European regions in terms of medical access, healthcare volume in search engines, to try to find out what are differences. And as you can see here, what we did for Germany, we did a comparison of different cities and looked at the search volume for skin cancer. And what we found out is that the search volume for skin cancer correlates to the data of the tumor registries. So in simple language, I can tell you that if a specific skin cancer, for example, is very common in one city, or more common than in one city than in the other city, more people in the city with more common skin cancer Google for it. And this can be very, very powerful tool for a new pandemic as we see it in COVID-19. And what we also did is, what we're also doing in COVID-19, what skin symptoms are looked up online, and to sort of get a map of Europe, what are the parts of the European population they're interested in terms of COVID-19 and also in terms of skin diseases. So in summary, the project European Patient Journey tries to understand the digital patient journey of Europeans during the COVID-19 pandemic to, at the end of the day, optimize people-centered healthcare for every European based on these findings to eventually have a shorter, successful patient journey for every European. Thank you for listening, and I'm happy to take your questions.
Thank you very much, Dr. Zink. The questions will be at the end of all presentations. Our next presentation will be from Dr. Arho Virki from Finland. Arho is working in Turku University Hospital, and his presentation will be about how to organize, harmonize, and commensurate data for scientific use, both via research as a service and through access to a secure data analysis platform. The presentation elaborates several different approaches that can be applied depending on the data type and analysis task. And the presentation is titled Exchange of Patient Data in Cross-Border Research. Please, Arho.
Hello, everybody. I'm Arho Virki. I'm Chief Data Officer at Turku University Hospital and Adjunct Professor of Medical Mathematics at Turku University. And the topic of my talk is how to exchange patient data in cross-border research. A short background of my institution. So Auria Clinical Informatics is a combination of Auria Biobank with biosamples and a Center for Clinical Informatics, which concentrates solely on digital information about patients. And our purpose as part of the university hospital is to combine data together and formulate data sets so that data could be used for better management decisions, but mostly we prepare research data sets for scientific research. And we also help public authorities to gain understanding of what's the status of the current situation here in the hospital. And as a background to this page, in Finland, we do have a new law. It's called Secondary Use of Health and Social Data Law in Finland. And in implementing that law, we have been thinking a lot how to combine data in a safe way so that it's both justifiable for the public that we use large numbers of individual data and that we can do it in a secure way. As an example, this is a graph from a couple of months ago from Southwest Finland, and we only have the numbers in specialized healthcare, but we are lacking the primary healthcare and other actors because it was problematic in a quick pace to combine the data in a legal and safe way. So we definitely would need a framework that would just work to combine the data. In the old times, when large data sets are combined, we have used meta-analysis technique, so to take the statistical information and statistically put that together, and it works sort of, but not always. One route is to propose changes in legislation so that we could handle larger sets of individual level personal health data and do analysis in that. But of course, we cannot have a centralized European database for all the European data because it would be it wouldn't be practical. And one thing is to write agreements and copy the data from one register keeper to another, which is an option, but it's always a bit cumbersome. We would need a better European health implementation framework that would just work. At the moment, we are implementing in Finland the FinData approach, where FinData is our public authority, which is the central register. And they have the mandate to extract and copy data from register keepers, formulate a pseudonymized data set for the researchers, and give the controlled secure access. And that's the centralized way. But there are cases where there's actually no need or it's impractical to move the data around. This is especially the case when we have genome data or digital images, where the sheer volume of the data is so huge that even with quick internet connection, it takes hours or days to move the data. So it's better the distributed computing. And in pattern recognition for images, this is the way it actually can be done. Another approach is that if there are same variables in each register keeper, but the population cohorts, the people are different, then we can circulate the computation so that the data sits, but only the algorithm travels around and get the results that way. And this is actually the way how the modern artificial intelligence computations in GPUs works. One round is one epoch, and one round is the round where the algorithm has seen the whole data once. And there's a promising new approach also coming called multi-party computing. After discussing with the researchers in a conference last summer, I understood that multi-party computing is a promising way of computing statistical, getting statistical results out of data where there are the same people are visiting different register keepers, and there are different variables from each people on the different registers. But it's it requires quite a amount of communication between those registers. Hopefully we get ready-made tools for R and Python in the future so that this will also be an option. So as a summary, we really need a safe, solid and accepted way of analyzing cross-border personal data in the scientific setting, because in this way, when it's safe and auditable, we can justify for the public that it's okay to use the personal data to develop science and medicine forward, because it's good for everybody that we get better drugs and better treatments, and we use less money and get more results with that. And when we think of the researcher, nobody actually wants to own the data. Researchers just want to use the data to get the results. So that way, I think that having a virtual European data pool is a very good idea. Thank you.
Thank you very much, Arho, to addressing these data-related questions very thoroughly. Our next speaker is Therese Fehler from Germany, from Munich. Dr. Fehler is going to share with us the perspective of ethics and proportionality in the context of COVID crisis, as this crisis is perceived as an example of preventive medicine, the chance to install a new digital health economy and to increase cross-border cooperation in terms of medical data exchange. And the presentation title is "What's the Damage? Proportionality and the Ethics of Crisis Response." Please, Therese.
Thank you for your kind invitation to this conference. I've been asked to comment on the theme of the conference from the perspective of ethics. But of course, since much more is to be said than as possible, I'm going to focus on the principle of proportionality. Now, this principle of practical reason is a demand for lawyers and non-lawyers alike. It concerns the response to crisis or conflict, whether political, medical crises, or indeed any judgments of daily life. And predictive technologies are part of that. Now, what is proportionality? Now, we tend to think that a judgment on proportionality is made with reference to a particular aim. And this is what the ethicist Oliver O'Donovan, drawing on the 16th century scholastic Victoria, calls prospective proportionality. As O'Donovan expresses it, insofar as judgment is forward-looking, constituting a law-governed context within which future acts, private or public, are to be performed, it must be proportioned to the state of affairs which it attempts to realize. If I want to open a locked door, for example, the proportionate action is to get a key, unlock it, and then walk through it. However, prospective proportionality alone is insufficient. Nothing tells us whether the aim itself is proportionate or not. Usually the question is answered by reference to the law, but the law cannot cover all possible scenarios. And this is particularly evident in crises such as the present one. If the aim of a policy or structure is too broad, we experience something called mission creep, the continuous expansion of the aims. And this phenomenon is familiar to military personnel and project managers alike. So in the response to the COVID-19 crisis, at least in Germany, we've seen a continuous shift of goals, from flattening the curve to decreasing the R value to below 1 to what seems now an entirely arbitrary number of daily infections. If the overall aim is to broadly protect life and health, governments and the public have nothing to apportion their actions to. Lack of an achievable, realistic aim also results in the proliferation of contradicting aims. This can even include irrational elements. And a good example are some hygiene concepts we encountered today. At best, they are cumbersome and somewhat ineffective to the point of being amusing, and at worst, such measures are forms of human rights abuses, including unlawful and unwarranted detention, solitary confinement, the deprivation of the right to family life or threat thereof, even for small children, and the denial of civic rights. Such measures create long-term physical, psychological, and economic damage, and indeed they result in damage to the health of the very people whose health is to be protected. And absent a defined aim of medical political action, predictive technologies often take center stage instead. However, depending on small input variations, they can result in vastly over dramatic doomsday scenarios, like a domino theory of sorts, as we saw from an early COVID-19 study at Imperial College London. Predictive technologies give us an idea of what could happen under certain conditions, but they don't tell us what exactly we should do. So the question is, how can aims be defined? And the way I understand Francisco de Vitoria is this: prospective proportionality needs to be balanced and indeed guided in terms of retrospective proportionality. What is the actual harm to be responded to? What's the damage? It is the reactive nature both of medicine and politics that keeps the proliferation of aims in check. Hence, for Vitoria, it was an injuria accepta, a received injury, that would warrant an adequate response. Of course, it didn't have to be an injuria perfecta. It didn't have to be finished. So if someone runs at you swinging a cudgel, you don't have to wait until you've actually been hit over the head to defend yourself. Scholars also differ as to how certain we need to be about a threat in order to act. For Vitoria, it merely needed to be in continuare, an emerging threat. And for Francisco Suarez, a couple of years later, the threat had to be in fieri. It must be happening already. Either way, for both authors, interventions cannot be based on mere speculation. Measures need to be proportionate to the harm that has actually been done, or is at least, or of which we have at least unequivocal evidence of impending harm. So in that sense, the Kantian emphasis on empirical evidence can strengthen rather than weaken a form of practical reason. And this also puts predictive technologies and preventive medicine in place. Predictions are relevant to a person or polity insofar as they refer to or extrapolate from existing injuries and indications. Prediction functions to fulfill a curative aim. Hence, the lower risk of the possible scenario, the less invasive the defensive or preventive measures will be. Now, what follows from that? In terms of the response to COVID-19, I think the implications are evident. The problem has not been so far incomplete knowledge of the behavior of the virus, but the definition of aims. And I think increasingly we're seeing political and legal pressure build up precisely because measures need to correspond both to the damage done and with a view to reliably predictable damage, if any at all, rather than grand aims such as protecting life. And insofar as the biomedical industries may also be adversely affected by the COVID crisis, and I'm thinking of shrinking public purses or a damaged reputation, they're not exempt from making their own judgment calls on proportionality. Needless to say, the promising tendency inherent in their technical developments alone will not suffice for that. Now, I think, in fact, P4 medicine can, and in many versions does, heed the principle of proportionality. And I think we're trying to implement that in my consortium, Digimate Bavaria. So in a project on familial hypercholesterolemia, we test for genetic diseases only when we have clinical indicators, and we test only for FH. And intervention is strictly guided by clinical responses. At the same time, the aim is to leave judgments to patients. They are concerned with their own diseases, because no preventive regime can adequately micromanage such highly personal decisions as those on health. And finally, a remark on the planned joint declaration of this event. In your draft, you write, I quote, "As a result, care can be more focused on the prevention of illness instead of curing diseases." On the grounds of what's just been said, I'd strongly recommend revising that. It should rather say the curing of diseases can be enhanced by prevention. There's no meaningful prevention of disease that doesn't have a curative function and horizon. And I think only with this in mind can any predictive scenario be said to have any practical merit. Now that's from me, and thank you very much.
Thank you very much, Therese, for addressing this very important subject also in cross-border healthcare. Now we will have our first poll. You can see on the screen the statement. And please read it and make up your position by clicking one of these three options. We have maybe 15 seconds to do this. Meanwhile, I would like to ask panelists to switch on your cameras and join the panel. So a few seconds still left to fill the poll. Thank you very much. Thanks once more for all presenters. We have now approximately 20 minutes for discussion. And I would like to start with one question to, the same question to each of you, and please maybe you can answer in order of the presentations. So we were talking about cross-border exchange of digital medical data and also e-services. And my question is related also to the poll. How do you see citizens' involvement in this kind of activity? How important is to involve larger groups in society to understand that medical data and health data exchange is as important as exchange of financial data or even more? Please, maybe Corinna would like to start.
Yes, thank you so much for this very interesting question. We, of course, have not a lot of time to think about it. But if I give a very spontaneous answer to that, I think it is two-sided. So the one side would be, my answer would be yes, the more the better. Citizens should be involved and they should be informed properly. And I think communication and education is the foremost important thing you need to do with citizens in this topic. On the other side, the more you inform people about it, so that would be the kind of half no answer, but actually I think I'm leaning more to yes, is that the more you inform them, the more issues you get. And I think data exchange is an important and difficult thing to do, but I think we need to move forward there. And I think the only way to do is like by involving all the citizens as much as possible.
Thank you. Sarah?
Yeah, and I agree with that, Corinna. And I'm just reflecting on the Danish and Swedish perspective towards this. There has been a number of studies actually, or polls among the citizenry towards the appetite to the use of their health and clinical data for research. And I think there is a very high level of acceptance for that. I would say, you know, up to the 70s of 80% would say they would love for their health information to be used for research, but under the condition that they are told what it's being used for. And I think that kind of fosters this sense of trust. I think citizens, at least in the Nordics, have a very high trust in public authorities, in the healthcare system, in the research environment in general. But being able to maintain that trust becomes even more important, and perhaps even more critical when we start to integrate other more personal sources of data into the conversation generated by people on an everyday level. So I think that the idea of informed consent is important. And of course, how we do that practically, that of course, as Corinna alludes to, is complex, but it's not something that we should get around.
Thank you very much. And by the way, the poll says also vast majority of answers were in favor of wider, more widely inform public about this opportunity. Next, Iris or Geir, how you would like to share your stage? Maybe Iris will start. You're muted. Yes.
Thank you very much. I find it very interesting to hear about it. And actually, the different things we heard, I also find it very important to cross-border actually to do it in the way that the public themselves can use it, and that it goes down to the public actually. To talk about the research is one thing, and the colleagues, that's on the meta-ebene, but I think also that we do need, and that's what we see at the moment, the support of the public itself, that we take the public with.
Thank you. Gail?
Yeah, I want to echo Sarah with, we are very prominent, or we are very lucky in our regions to have high confidence in healthcare systems and in authorities, which actually make this possible. And I think sharing data as citizens makes us contribute to the ecosystem, because we want to move into more preventive health. We want to have more accurate treatment, and patients are, like also mentioned in some of the speeches today, they're highly competent on their own disease. And the only way to get there and to make our healthcare system move forward in a financially viable way is to contribute from all parties. So I think it's kind of a closed loop, and make sure people trust in the ecosystem and want to take part.
Yeah, this is funny that when we travel, we use our bank cards everywhere, but we can't use our health data even to share them. So this is quite weird. Alexander, from the physician's point of view, usually in Europe, physicians are not very happy to share their own data, even with patients. What about vice versa?
Yeah, that's true. But I fully agree that we should include every citizen. And as some people already said, medicine is shifting from treating a patient to preventing diseases in citizens. So obviously it's only working including the healthy population, which are the citizens. And the more citizens are included, the better. But of course, especially in Germany, data security is a big issue. We're not so confident so far in Germany as you are in the northern countries, but I'm hoping to get there pretty soon.
Thank you. Arjo? What is researchers' view?
Like Sarah said, we have a high confidence in the Nordic countries, in the public authorities. And actually, we started collecting the consents on the biobank setting 2014. And actually the percentage is, it's not around 70, it's around 95% that people are willing to give out their data. Then there are a few people who are reluctant, but most people are. And the problem with the current legislation is that in the biobank setting, is that it's assumed that people are not willing to give out the data, and then they need to be asked for consent. And at the moment when we are updating our legislation for the biobank, it's proposed that it's assumed the opposite, so that we would by default assume that people are willing to give access to the data, and then you have option to opt out. It's that way.
Great, great. Yeah, very. I think proper approach. Thank you very much, Teresa.
Well, we've actually had a couple of workshops with people working in our consortium in Bavaria, and I think when you hand out this number, how many people are willing to donate their data, you have to ask, well, what are they actually imagining? What's the image they're seeing when they're donating data? And then a lot of people they look at their doctor and they're like, oh well, he seems a reasonably nice guy, and just he'll do a good job. And then of course on the sort of operational level, it kind of gets a bit more tricky. And there's a huge difference kind of between this sort of patient doctor encounter and the kind of huge technical dimension that everybody in this event is talking about. I mean, big data, big anonymous data, exchange data, big technical and informatics side to it. And that very soon has nothing to do with what people see when they go to the doctor or take part in a study. So I think what we're seeing is that it's important to connect it to a particular region, to connect it to a particular country, connect it to your city even. We have a sub-study in my consortium is connected to the region of Augsburg. So there's almost a patriotic element, or like a kind of city patriotism. And also, as Corinna talked about the cross-border thing, I mean, there's a particular kind of cross-border culture and sense of the cross-border region even in that part of Germany and the Netherlands, for example. So I think there needs to be a sense of where does this data donation, where does that sit within the world and the lived world of patients? And when they then, on top of that, have the sense, all right, here's some competent people sorting out the security, the data security, because data protection is personal protection. So when people have that sense, these two columns, as you will, then I think you can make sense of those 95%.
So do you think that there is a need for specific consents for different purposes?
See, that's the thing. If you have a sense, we know this from, I think, Estland, where there's like a national biobank, and I think in Israel as well, there's a greater sense where this is a particular institution. They have a certain mission. They have, protocols in place, what they're going to use the data for. Then I don't think you necessarily need a very narrow consent for each and every single study. And that's already possible within the current GDPR.
Right. Thank you very much. Now I have a couple of questions from the audience, and there is Frederick's question, who is describing the situation where in Sweden a refugee died because of the non-usage of universal identification number. And the question is that now the regions are asking for biometrics when patients are being treated. What are the other EU national perspectives on this? This is a question maybe not addressed to any of presenters. However, in cross-border settings, what kind of experience you have to identify persons from different nationality, and have you heard any pan-European activities? There is definitely EU e-health action plan where the data exchange rules are elaborated. It's ongoing process, but do you have any news, any specific tools how to identify and then assign data to persons without social security number or ID number? So it's clearly the topic what should be elaborated on. Let's continue. There is question to Corinna and Sarah, and it's as follows. Neighboring countries seem to be a good starting point for cross-border collaboration on data exchange. Should we focus in a first step on this instead of trying to find a solution for whole Europe?
Yeah, I saw that question already. Thank you very much for that. I actually want to add something to the previous discussion because as a German citizen living in the Netherlands, working in the Dutch-German border region, now listening to all the northern countries where the acceptance is rather high. I know from the whole network in Denmark, where if I go on one day in this one hospital, on the other day in the other hospital, data is automatically be shared. And this is even within Germany or within the Netherlands already a problem. We had now, as an example for the Corona patients, where we had a very high peak in the south, and all of the patients were moved to us to the north because we had a lot of capacity still open. But it seems that it was very difficult even within our country to move the data with the patient. So it is actually nationally already also a problem in the more middle southern countries compared to the northern countries of Europe. So I'm actually wondering if what we can learn from the northern countries, why is your acceptance so high? That's the first thing. And how can we use maybe tools or ways you've developed over the last years to implement also nationally better to share data? And on top of that, to the question from Oliver Stenzel, I totally agree. I think that's actually what we've been doing for the last 15 years in our field. We use the border region as a living lab, as a proof of principle, as a pilot. And whenever we think this works out and we test it in a lot of different ways, we will then try to move it further away from the border to make it more regionally and more nationally. So I think this is definitely maybe an easier starting point, or you need to start there and you need to start bottom up, top down, and at somewhere in the middle you will meet each other to find a solution. Yes, but yeah, I think this is we always talk about the Europe of the capitals and the Europe of the border regions, and I think if both try to solve this problem with their own ways and their own tools and people, at some point we will meet and hopefully have a solution for everyone.
Thank you. Sarah?
Yeah, and I just wanted to add on to Corinna's thoughts, just to address Olivia's question as well. I fully agree that in a cross-border region, you have a bit more ability to pilot and to see what works, and then potentially apply those lessons across Europe. At the same time, I mean, we are working within an European framework, so we kind of have to work parallel as well. To see, okay, what's happening in the regions, can we learn something for that, but also work from a top-down perspective, a more framework EU thing, and then try to kind of find a way forward at the same time rather than wait for one or the other. But to your comment on the Nordic countries and why people trust so easily, I don't have a very concrete answer for that. I mean, I think it could be cultural. I mean, if you look at the Edelman Trust Barometer, just the way that people relate to institutions in the Nordics could be different from other countries. I haven't looked in more detail there. But I know that there has been a lot of push towards going digital in healthcare. For example, in Sweden, we have up to, I believe, 95% of all prescriptions are e-prescriptions. So no more paper prescriptions, but everything is digital. And you don't have to, you know, find a lost paper, you get it straight at the doctor's office and so on. And I know that in Denmark, there's a similar shift as well. So I think there is this very awareness that we need to work in a much more integrated way within the regions. But, you know, if it's of any consolation, there are still problems. We normally like to say in Sweden, there are 21 different healthcare systems because we have 21 regions. So we also have 21 medical systems that need to talk to each other. And so there are national efforts to kind of integrate it on a common platform as well.
Thank you very much. I will follow up this discussion and ask other participants, Geir, Alexander, Arjo, about scaling up your services and your work. How do you see, like we have very good examples from cross-border implementations. Let's start from Alexander, for instance. You're doing really great work in patient pathway. How to scale up it? Should it be done through specialist society or through governments?
Yes, and that's a very good question. And what we did, so we had a pan-European project working on itch. And what we did is we partnered or teamed up with the European Society for Itch, obviously. And they gave us all the partners. And the big problem is that there are really regional and local differences. So even in Germany, somebody in Bavaria has a completely different expression for itch compared to somebody in Hamburg, for example. So you need some local guy who really knows what's going on there. And that's the big issue. That's the big problem, but also what makes it interesting. So from my personal view, you need the experts on a very local basis and then to get the big picture. And then if you understood the local image or the local picture, for example, by showing it how it works with a medical problem like itch, then you can scale it up also to other diseases, but also to other regions. So you have like a big map.
Thanks. So this is like a semantic interoperability. We have left 2 minutes. Arjo, your quick comments, please.
Yep. So scaling up, that's actually what we are doing at the moment in Finland, because we have a very large social security reform going on. That's why I've been so busy during the last couple of weeks. But anyway, it seems to be that it's firstly it's technical, but it's a shift in doing the work. So there needs to be people who are responsible of the data, but also there needs to be scale up in the skills, so that for every data owner, there needs to be a data coordinator that can actually go to the database. So it needs to be streamlined, and we cannot outsource. We need to take it into the hospital. So that's why we are building the data scientist capability in-house. We are not buying it from outside.
Thank you very much. Geir, Iris?
Well, I think we have short time left, but I think back to the first question with trust and interoperability. I'm a technological optimist, and I think the technology goes with us because when it comes to sharing data, I also think that what we see with how we share data and the blockchain technology that could also help us to secure our patient data is something we will see going forward. It will take time, but it will definitely be a game changer. And related to Alexander's comment, I think it's not about only itch, it's all across the healthcare system. It's so granulated, and I think technology could help us to crowdsource information and to also
consolidate crowdsource information. So
thank you very much, Geir. I'm sorry to interrupt now.
It's a good thing.
I would like to thank you all for excellent discussion, of course, and also for excellent presentations. And for all participants, now our next session, which is moderated by Dr. Lars Lindskjöld, will start in 15 minutes in 12:25. And I cordially invite you to come back after a short coffee break. Thank you very much for all your contribution and for the audience.